My name is Dr. Getrud. I come from Ifakara Health Institute, but currently based at MUHAS, and I acknowledge the presence of my teachers here, including Professor Karim. I'll be presenting about HIV and treatment outcomes among adolescents in rural Tanzanian cohort. So through this slide, I'll only say we are all aware that sub-Saharan Africa harbors more than 80% of people living with HIV, and that has been talked about before. And across the HIV care cascade, from diagnosis to initiating ART, retaining people living with HIV in care, all these also stand as loophole for these individuals to disengage from care and re-engaging later on in care. And during this time when they're outside care, they continue driving new infections in the communities. And as we think of the 95 target, and even though we know numbers are showing that new infections are declining, we need to think of these individuals. And so I'm presenting today data that's from the Kiulako cohort. Kiulako stands from Kilombero and Ulanga antiretroviral cohort. It's based at the Chronic Disease Clinic of Ifakara at the St. Francis Hospital. It is in southwestern Tanzania. And the clinic was established in 2004, and the cohort itself was established in 2005. And this is around the period where majority of the CTC clinics in Tanzania were also being initiated. And it's enrolling consenting individuals living with HIV, and all ethical procedures are always observed. The cohort performs a lot of research in various research areas such as HIV, including the virological outcomes that I'm presenting today, HIV affected and infected families and comorbidities, but also TB, and also in the areas of non-communicable disease. A little bit of a nutshell about the cohort. Since it is its initiation, it has ever enrolled over 12,000 individuals. Loss to follow-up is a problem, and I think this is a common problem across a lot of HIV care clinics. We have lost follow-up of around 5,000, and active follow-up of around 4,000 to 5,000 individuals. Enrollment, annual enrollment has been steady around 400 to 500, excluding the peak in the beginning of the HIV care in Tanzania, where majority of people were being diagnosed, and also a little bit of a downfall during the COVID years. These are a little bit of milestones at the CDCI since it was initiated. The important one is in 2012, where the electronic medical record and the database was initiated to keep all the data of the consenting individuals enrolled in care. The rest is really different projects and units that are being introduced at the clinic as years go by. Coming back to our group of interest today, that's the adolescent. After now you know a little bit about the cohort. It has been said already that adolescents, looking at the decline in new infections, decline in HIV-related mortality, adolescents do not really enjoy the same benefits as it's been stated in other age groups. And that's also include treatment outcomes, as this age group continue to experience poorer HIV treatment outcome. And looking at what has been presented by the first presenter today, when she thought of 66, 99, and 90% down the 95, 95, 95, we should really think of the 34% who are not knowing if they are living with HIV before we continue celebrating the 90% who are suppressed, because we still have people who are driving the infections in the community. So in this analysis, we looked at viral suppression, adherence, and associated factor among adolescents enrolled in the Kiulako cohort after the implementation of routine viral load testing in 2016-2017. And this it was of interest to us because we see in a lot of research setting, many things are being controlled, and this also in turn fosters adherence. So when we assess viral suppression among adolescents or any individuals in a very restrained research setting, it tends to overinflate the treatment outcome. So this analysis was completely for routine viral load samples. And it was cross-sectional, nested within the Kiulako cohort at the CDCI, where we included adolescents who had been on treatment for at least 6 months at the time point of their first viral load assessment, and with a clinical visit recorded. Definitions were in accordance to the national guidelines, where viral load above 1,000 was considered unsuppressed, and adherence was assessed by visual analog scale, safe adherence, and pill count. So we ended up including 260 adolescents who had fit all our inclusion criteria of age and time on ART before testing the viral load. And this is a summary of the characteristics of our participant. And just to say a few points is that 23% of our participants had virological failure of viral load above 1,000. And majority of our participants were aged between 10 to 13 years, were perinatally infected, and had HIV WHO stage 3 and 4. And then we went on and looked at, when we assess adherence, how does it correlate with the viral load outcome? Because we expect adherence to be assessed at every visit, but as Dr. Joan stated, viral load starts to be assessed only 6 months after initiated of ART, and then annually if you're suppressed after that. So for the assessment of self-report, the self-report of adherence, those looking at the unsuppressed viral load, 42% reported that they missed at least one dose over the past 4 weeks, whereas only 20 in the unsuppressed group reported the same. And the percent agreement between self-report adherence and virological outcome was 76%. But then looking at pillbox and visual analog scale, the percent of agreement between adherence assessment and viral load outcome were rather lower than self-report adherence. And this tells us, when we ask these adolescent questions, or when we try to assess the adherence, will that really translate with what goes on with HIV replication within their system? And then we looked at factors that were associated with viral suppression, and with borderline significance, we saw a tendency that being male was associated with viral suppression. But of not a surprise, higher CD4 count was associated with higher likelihood of viral suppression, and also safe report of never missed ART in the past 4 weeks, and having not disclosed HIV status, which points us to think around stigma to people living with HIV. So lessons that we learned from this analysis was that viral suppression among adolescents, even in the rural setting, is still below the UNAIDS viral suppression goals. And this calls for age-appropriate interventions to improve viral suppression. And we should think again as we assess adherence at every visit, what are the appropriate methods to assess, and probably we should also listen to the adolescents themselves on how best or what best can reflect their adherence to ART once we assess it when they come to clinic. And probably it's calling for using at least more than one method to assess for adherence. So I thought I should also share one slide which is dear to my heart. And this is about improving HIV testing among adolescents. And when we think about how adolescents get access to tests, get enrolled to care, so that we start analyzing all these down the cascade of care, they need to be tested. And the age of consent for HIV testing in our country is still is around 15%, but majority still are not aware of that. The adolescents themselves, the care providers do not implement that. But looking at the whole of sub-Saharan Africa, we see now majority of countries have lower age of consent of 12 to 14 as compared to earlier years as 2013. And I think this would point to findings that were reported by one of the previous presenter who was reporting HIV testing in Eswatini, it was, against Tanzania, where there was only 43%. And I'm aware that in Eswatini, the age of consent is down to 12 years. So we should think about all these things as we think of our adolescents. And that brings me to the end. Asante sana.